Okay, guess we're all back in, and we're going to take a look at thyroid problems. No matter who you treat, no matter what kind of a provider you are, you're going to see people with thyroid problems, particularly if you treat women. Again, women have thyroid problems about 3 times more often than men. So this morning we're going to take a look at what you might see in your office. Now, I must tell you that the American Thyroid Association, last 12 months, has published 496 pages of new guidelines. And if you have chronic insomnia, I suggest you read them carefully. However, for the rest of us, we're just going to try to hit the highlights. So I'm going to look at a few cases, and I would urge you to just ask your question after the case. I know that Randy told me he has a weight reduction program in place, and so he'd be glad to throw that microphone at you after a case. I think that'll be more relevant. Okay, so take a look. First of all, you have to look at a little boring biochemistry. Remember that the hypothalamus produces thyrotropin-releasing hormone that goes to the pituitary that produces thyroid-stimulating hormone that then goes to the thyroid and causes it to make 2 hormones, thyroxine and triiodothyronine. Triiodothyronine, or T3, is the active hormone, but we make mostly inactive hormone, or levothyroxine, T4. So we make T4 and we convert it to T3. We convert it to as much T3 as we want during any given day. So there's a variable amount of T3 that we make every day. Now, I must tell you a little secret about the pig. If you chop up a pig thyroid, your ratio of T4 to T3 is about 4 to 1. If you chop up a human thyroid, the ratio of T4 to T3 is about 20 to 1. Oh, little different. Pigs are not human, and humans are not pigs. Okay, well, most humans are not pigs. All right, so anyway, let's take a look at what we're going to do. When you're going to screen for thyroid disease, you're going to use a TSH. It's inexpensive. It's obtainable in less than 24 hours in most labs, and it will give you the diagnosis 85% of the time. If the TSH doesn't work, it doesn't really go where you'd like it to be, you can get a free T4. The TSH is not helpful if the pituitary isn't working. Remember, the TSH is how the pituitary feels the thyroid is doing its job. It's sort of like all those people looking over our shoulders. Well, think of them as the TSH. Okay, so it's not helpful if the pituitary isn't working. So you said that twice. But many of the people I see coming to my office have had their pituitary taken out, and someone is still measuring the TSH. So again, remember, if you don't have a pituitary, TSH doesn't work. Okay, so we said the TSH is our go-to screening tool because it's 85% accurate, and the free T4 is best when the TSH isn't helpful. When you say, oh, I think the patient has a disease, but the TSH isn't helping me out. The total T4 is not as useful because it's affected by binding protein. And particularly, if you're taking care of women, frequently the free thyroxine index, which corrects for binding protein abnormalities, doesn't work very well. Now, I know a lot of you are in GYN, and I had a call from my friend at GYN the other day. He said, you know, something's wrong here. My total T4 in this patient is 60. And he said, upper limit of normal is 10. They shouldn't be hyperthyroid, right? I said, well, do they look hyperthyroid? He said, no, they look fine. I said, okay, I seldom get to look at the stereotypes in front of my GYN colleagues. I said, the patient is using Yaz or Yasmin. He said, oh, that's amazing. How did you know that? Well, some of the oral contraceptives really raise the binding protein a lot. And so the patient looks like they have hypothyroidism when they don't. So use the free T4. It's just really better all around. Okay. Now, the U.S. Preventive Health Task Force said to us the other day, actually about April, it said, don't screen the asymptomatic patient for thyroid disease. Now, they didn't mean that you shouldn't screen people you're concerned about. What they meant was just because Mary Jo Schmidlap comes in to see you for her well person exam doesn't mean you have to get a TSH. Particularly, they're focusing on not getting TSHs on older people, people over the age of 60, frequently have a slightly elevated TSH, and that may be normal for this population. And so the American Thyroid Association says, be careful screening those people because you don't want to overtreat in that age group and cause cardiac arrhythmias and bone loss. So over the age of 60, we don't have to screen everyone that comes into the office. It's not a part of your well-person anymore, and they're going to try not to have it paid for, more's the pity. Okay, so this is case one. You might call her the asymptomatic lady. This is a 45-year-old lady she brought to the ED after she had syncope at work. And her hemoglobin, remember when you go to the ED, they screen a lot of things. Hemoglobin was 4. Uh-oh, sodium 124. Well, right away they said, something may be wrong with this lady's thyroid. They got the TSH and it was 116. Normal is 3.74. There is something wrong with this lady's thyroid. She has primary hypothyroidism. So I said, okay, free T4 was 0.6, below normal. Free T3 was 1. Oh, that's really low. And her temperature is 97, her pulse is 64. She had delayed reflex relaxation time. That's one of the very good ways to look at for hypothyroidism on physical exam because it's pretty sensitive. So up is normal, down is slow. Okay, so again, she said, I feel really pretty okay. I just have fatigue. Okay, who in your practice does not have fatigue? Right, refer them to me on all my patients. Okay, so she had mild fatigue. Now, you say, wait a minute, she was grossly hypothyroid. And if I would have screened her? No. The key here is that when people are very hypothyroid, their brain doesn't realize that they are sleeping all the time, that they're having paresthesias. Their brain recognizes that the reflex relaxation time is slow. But again, they don't have a whole lot of symptoms because their brain is hypothyroid. So when you treat people like this lady, the take-home point is that you're going to tell her, oh, Mrs. Schmidlap, you're not going to feel well for a couple of weeks. It's going to take about 3 or 4 weeks. And during that time, your hands and feet may tingle. You may feel like everything's really loud because you were deaf before and you didn't realize it. You may not feel better for the first couple of weeks. You may feel worse, but that's your brain's waking up and telling you the rest of your body is not doing well. So if someone's very hypothyroid, you're going to chat with them about the symptoms they may well collect while you're getting them back to a euthyroid state. Okay, so would we have screened this lady anyway? Her mother had hypothyroidism. Very important. So who are we going to screen? I have to tell you, it's really unusual that the American Thyroid Association, ACE, and the Endocrine Society agree about anything. And so these are the risk of the population they agree with. And they said, okay, who are we going to screen? Well, what is the cause of thyroid disease the vast majority of the time? It's hereditary. And so hypothyroidism, hereditary autoimmune disease. In the United States, about 95% of it is due to hereditary autoimmune disease. Hyperthyroidism, again, hereditary autoimmune disease. Multinodular goiter, not an autoimmune disease, but for sure, hereditary. And then, of course, we have iatrogenic causes. So they said, okay, who are we going to screen? Anybody with autoimmune disease. Hypothyroidism, hyperthyroidism, common autoimmune disease. So if you see anyone with, for example, type 1 diabetes, celiac disease, rheumatoid arthritis, all of those people we heard about in the previous lecture, you're going to screen them for thyroid disease. Iatrogenic causes, again, radiation to the head and neck, amiodarone that we'll talk about, lithium, chemotherapy, the list is fairly long. I want to point out iodine on the end here. A lot of my patients come in and they say, and I'm taking an iodine supplement. Okay, if you have thyroiditis and you take excessive iodine, what does it do? It makes matters worse. What do you think amiodarone does? It causes thyroiditis in most cases. So again, encourage your patients who have thyroid disease not to take extra iodine supplements. It's probably going to make matters worse. It isn't going to make matters better, except in the rare case where you have an iodine deficiency goiter. In the United States, that's a really pretty rare case. So excessive iodine supplementation is not your best effort. We'll talk about pregnancy as we go along. Okay, we also check people who have associated conditions to thyroid disease. For example, the person with atrial fibrillation. Yes, some of them have hyperthyroidism. Good idea to screen. Dementia and depression and obesity. We fervently hope that those people are going to have hypothyroidism, but 95% of the time, they don't. But nonetheless, if your patient has depression, dementia, or obesity, probably a good idea to check. As our previous speaker yesterday said, yes, if they have depression and they're hypothyroid and we fix that, the depression may well get better. Anybody with a family history of thyroid disease, always ought to screen those people. Palpable thyroid abnormalities. And people say, oh heck, I can never feel the thyroid anyway. That's what thyroid ultrasounds are for. Not to worry. If you think you feel something, get an ultrasound. But remember that the thyroid is located between the sternocleidomastoid muscles and the trachea. We all can feel those, right? So you just put your fingers in between, tell the patient to swallow. When it moves is generally the thyroid. So, okay. Now the other people we ought to screen, and we found that over the last 5 years, are the people exposed to endocrine disrupting chemicals. And in fact, you all know what endocrine disrupting chemicals are. They're selective estrogen receptor modulators. You're familiar with tamoxifen, cloloxifene, basodoxifene, but they also occur in other areas. So what do? They bind to the hormone receptor and they either block it, so the hormone is made, or they can trigger irregular activation of those receptors. And remember, thyroxine goes in and intercalates in the DNA. And so that's a very important endocrine disrupting chemical. A lot of the hormones go into the DNA and intercalate. And when they do, if you change them erratically, endocrine disruptors have been really linked to a lot of cancers, ovarian cancer, for example. They've been linked to childhood obesity. So they're important to us. And one of the things we need to add to our list of screening people is people that are exposed to polybrominated diphenyl ethers. You remember that thyroxine, or maybe you don't remember, thyroxine is 2 amino acids, 2 tyrosines stuck together. And so it has 2 aromatic rings. And anything with 2 aromatic rings has a tendency to bind to the thyroxine receptors. A lot of the endocrine disruptors do have aromatic rings. So again, structure related to thyroxine, and people exposed to this have more hypothyroidism. So who are you going to screen? The people who are on construction sites inside, the people who install carpeting, the people who work in upholstery factories, the people who are inside and exposed to fumes from high-impact plastics. Add those people to your list of folks you're going to screen. Okay, case 2, wishes to become pregnant. Now, she's a 26-year-old lady. She's coming for her initial visit. She hasn't had a period in about 8 months, but she's on oral contraceptives. And does everyone have withdrawal bleeding? No. So she's pretty asymptomatic, but her mother was hypothyroid, so we're definitely going to screen her. Physical examination was pretty normal, except her thyroid was enlarged. You can actually see it. She tips her head back and swallows. You can see it move. So she has an enlarged thyroid. It's firm. You don't feel any nodules. You want to feel those lymph nodes in the neck. Lymphoma of the thyroid is rare. It almost always presents with lymphadenopathy in the neck by the time the patient comes to you. So you want to make sure you feel for lymphadenopathy. Thyroid cancer, yes, central lymphadenopathy. So again, when you feel something wrong with the thyroid, be sure and kind of move over and feel the nodes. She has no palpable nodes. There we go. So what to do? Now this, you don't have to use you don't even have to answer. You don't have to raise your hand. You can just think about this. Would you screen this lady for thyroid disease? Well, obviously, she has a family history and a palpable abnormality. So we got to a 5. And if the TSH is normal, she has a goiter. It's a trick question. Would you treat it? You don't have to answer. I'm going to person. Well, I wouldn't treat it right right away. As a matter of fact, she probably, in the United States, again, more likely to have an enzyme deficiency goiter, so she's doing okay. The TSH is normal. Her thyroid got a little bigger so that she could make enough thyroxine to shut off the TSH, and so she's doing okay. So don't think I'd really treat that person. What, any other tests? Do that, thyroid ultrasound. Now, just because we do thyroid ultrasounds in the endocrinology office doesn't mean you ought to get them on everyone, just almost everyone. We need the money. Okay, so, again, any palpable abnormality, anything that you feel is wrong with the thyroid, it's very low radiation exposure, and it really works. So, be sure you do it. Okay, let's look at this lady's lab. Oh, TSH is 28, normal is 3.74. So again, she has primary hypothyroidism. And are you going to treat? You bet. The American Thyroid Association and ACE guidelines, TSH of greater than 10. Some people say 10 or greater than 10. There's a little controversy about that. But at any rate, when you get up to this level, usually the free T4 is beginning to get low. Statistically, it's low a fair amount of the time, so you ought to treat those folks. She said she was asymptomatic. But if you look over here, look at an exam, her blood pressure is 140 over 96. And yesterday you were saying that 140 in your office is, that's hypertension. In people that you guys treat, this age group, that's really hypertension. And look at that diastolic pressure. Whoa, high diastolic, slightly elevated systolic, characteristic of hypothyroidism, narrow pulse pressure, hypertension. And her pulse is 56, and she had a delayed relaxation time. You know what else she has? Delayed cardiac contractility. Now, in her age group, that's not going to be a big problem. If you're 60 and you have that, it can be a very significant problem. It can cause congestive heart failure. So, want to remember that people with a TSH of 10 have some cardiac abnormalities that are inherent just because of their hypothyroidism. Okay. We're going to replace this lady as a brand name necessary. How many of you have people come in and say, I only want to take Synthroid? Right. Okay. No. The answer to that question is that marketed levothyroxine has to be equivalent by high-performance liquid chromatography. There's a range there, but it's not clinically significant in most people. So most people can do very well with inexpensive, generic levothyroxine. And the brand names generally are going to cost more unless your insurance company has made a deal with that particular company. So, again, the American Thyroid Association says avoid desiccated thyroid or combinations of T4 and T3. We'll look at that more closely later. But that's because, as we talked about, you make variable amounts of T3 every day. If you don't need as much, you don't make as much. And in patients who are age 60 plus, you can get cardiac arrhythmias by giving them extra T3, so you have to be very careful if you're going to do that. Okay, so how much L-thyroxine? 1.5 to 1.7 mics per kg per day, up. Except the American Thyroid Association this year said 1.6 micrograms per kilogram per day. These people really split hairs. But at any rate, that's the ballpark. And if you give people that dose, you're not going to make them excessively hyperthyroid. They'll generally be in the right place. And if they don't have cardiac disease in your young population, you can start out with your calculated dose. I see people come in and say, well, I was on 25 micrograms for 2 months and then I went to 50, and they're still grossly hypothyroid. Get on with it. If they don't have cardiac disease, calculate the dose, put it in your mouth. Okay. The requirements are increased by medications that speed metabolism, but I don't see many people on Dilantin or Phenobar anymore. And mainly, we're looking at things that interfere with absorption. And so iron and calcium and herbals. Remember that we said levothyroxine is an amino acid, has a negative charge. If you take it with anything that has a positive charge, like calcium or iron, it complexes and whizzes right out the back end. So again, you want your patients to take their thyroxine separate from their multivitamin, at least 30 minutes before eating. They don't have to get up in the middle of the night. What I tell my patients is, you can take it in the morning, you get up, right by your toothbrush, And first thing you do is you take your thyroxine with about 8 ounces of water. Then you go along, you fix your hair, you brush your teeth, and so on and so forth. By the time you get to breakfast, it's about 20, 30 minutes. That'll probably do it. Otherwise, you don't take anything else when you go to bed. Just don't eat right before you go to bed. That's a good way to decrease your rate, by the way. And take your thyroxine as you go to bed. It doesn't matter what time you take it. You just need to have it separated from minerals and from many food, lots of food, by about at least 30 minutes. Okay, here we have pregnancy, and the new guidelines came out in 2017 for pregnancy and hypothyroidism. Remember the patient we talked about wants to become pregnant. So, how about if you're pregnant, what do? We're going to monitor your TSH, and the new guidelines from the American Thyroid Association, the Endocrine Society, and ACE say please use the TSH. It's very accurate, and you can use trimester-specific TSHs. But if you look at this slide carefully, I know you don't look at most of these slides carefully, but if you look at this slide carefully, you'll see that 2.5 is prominent here. So if you have your patient less than 2.5, TSH of less than 2.5 during their pregnancy, that's probably going to be okay. That's very reasonable. Whole thing. Now, ACE suggests that if you have a reproductive age woman coming to your office and you're treating her for hypothyroidism, that you just get her TSH to less than 2.5 in the beginning. You say, she's going to need more thyroxine during pregnancy. Not always. If you have her TSH less than 2.5, she may not need more thyroxine. So please don't say, oh, you're a Joe, when you're pregnant, double your thyroid. I had somebody actually do that. You don't want your pregnant patients hyperthyroid. That leads to fetal wastage. Subclinical hyperthyroidism in pregnancy is pretty well tolerated, but frank hyperthyroidism is not. And we said the TSH turnover time in most labs is about 24 hours. So what you say is, Mary Jo, when your pregnancy test over the counter is positive, you let me know, we'll get a TSH, you find out you're pregnant, get a TSH, we will then adjust your thyroid hormone if it's needed. But again, there's no harm in starting your reproductive age ladies on enough thyroxine so that their TSH is 2.5 or less all the time. And I take care of a lot of pregnant patients with hypothyroidism, and most of mine increase their thyroxine by maybe 25 micrograms at 50 at the most. So you don't have to increase it very much if you have their TSH 2.5 or less to begin with. Okay. They say, please use only L-thyroxine. Anybody have people on desiccated thyroid who are pregnant? Yes. Well, and that's because you and I get them. But yes, remember desiccated thyroid was all we had for a long time until they really got synthetic L-thyroxine, so you can manage it. Just have to be very careful that you check the TSH and monitor carefully monthly during the first 5 months. Okay. Also, your pregnant patients should be supplemented with iodine. The Endocrine Society says that so many of us are using Himalayan sea salts and various other salt preparations that don't have iodine, that now pregnant women may need extra iodine, and so you might as well just give it. But I need to ask you, do prenatal vitamins now have iodine supplement? Not yet. They're supposed to be coming out with iodine supplement. Anyway, if they don't, iodine is available in any health food store, any pharmacy. Okay, are there questions about that? No. Okay. So, this is a lady who's 46 years old, and she's presenting with fatigue, swelling, paresthesias, constipation, thickening of her skin, and amenorrhea. She lost her lateral eyebrows. Just kidding. Hardly ever see that in hypothyroidism, really. But she has amenorrhea. Does that bother you? It's supposed to be too much blood, not too little. Actually, the thyroid didn't read the textbook, and people can present with amenorrhea, with irregular periods, with heavy bleeding. A thyroid disease is sort of not a respecter of your uterine lining. So you can present with almost any finding in terms of your uterine bleeding. exam, again, she has that narrow pulse pressure. See, she has a slightly elevated systolic pressure, a really elevated diastolic pressure, a pulse of 56. She's 5 feet 2 and she weighs 180. Okay, do you think when we fix her thyroid that she's going to lose a whole lot of weight? 2%, roughly speaking, sometimes 5%. Not a whole heck of a lot, I'm sorry. Okay, she also has periorbital puffiness. Look for that in your hypothyroid patients. It really isn't baggy eyes, it's all around. It's more like a raccoon, and they really are swollen all the way around. She has delayed reflex relaxation time. She has no goiter. Well, lots of people with autoimmune thyroid disease get hypothyroid, don't have a goiter. So that doesn't worry me. Then came back. Oh dear, the fellow said to me, look at that, the TSH is normal. I said, well, it's not a crime, it's just normal. Okay, the total T4 is 3.2, the free T4, a free thyroxine index rather is low. We use the free thyroxine index because we use the total T4. And the free T4 is low. So what does this lady have? She has secondary hypothyroidism. There's something wrong with her pituitary. Remember we said if the pituitary isn't working, you can't use it to monitor the thyroid. And her prolactin was 536. Well, you know, when you have primary hypothyroidism, thyrotropin releasing hormone actually stimulates prolactin. So you have galactorrhea, primary hypothyroidism. You have an elevated prolactin. The prolactin is not 536. It's usually 50, 35. Her pregnancy test was negative. FSH was 2, and her cortisol was 4, so that's really low. Looks like she has pituitary wipeout here, right? So she has a prolactinoma that has just smashed the rest of her pituitary cells, and so she has secondary adrenal insufficiency, secondary hypothyroidism, and probably secondary hypogonadism. So, again, replace the cortisol first. And she is an interesting lady. We treat prolactinomas, remember, with medication. I'm sure many of you do as well. And she was on, this is a while back, so instead of being on more modern drug, berberine, she was on bromocriptine, which makes people do strange things. And she was a preacher's wife, a minister's wife, and she got up on the barn roof and mooned everyone. We took her off the bromocriptine. So, moved on to the berberine, she did very well. So, how are you going to replace these people? You're going to replace them with levothyroxine. Again, exactly the same calculation. Or if you're a hair splitter, 1.6 mics per kg per day, and follow the free T4. So what you're going to do, exactly the same thing with this lady, except you're going to follow the free T4 and not the TSH. Okay, questions? Okay. All right, these are kind of interesting folk. And I'm sorry this is a man, but he was the one with the disease. So here you go. He's a 35-year-old male with primary hypothyroidism since childhood. Do I have any women with this? Yeah, I have one or two. And he's on 150 mics of levothyroxine. This is calculated dose. Things are going well. Sees you for an annual visit. He's asymptomatic. He's feeling well. Oh, fine. So you get a TSH. Uh-oh, 456. Well, so I had a student, I have a collection of trainees with me. They always make my life so much more fun. And a student came in and he said, oh, he must have myxedema-coma. I said, well, he is walking and talking, so I don't think he has myxedema-coma. He said, well, what else can this be? I said, how about something wrong with the TSH? And, you know, I have to tell you that it's incredible that people don't think about that. You know, the TSH is abnormal. They say there must be something wrong with the thyroid. 85% of the time, you're right. 15% of the time, you're wrong. So you just have to think, oh gosh, he's walking, he's talking, and if you want to know if somebody is at risk for myxedema-coma, what you do is you count their respirations. Now I know we all write down 15 or whatever, but this time you don't do that. You really count the respirations. And if they are 10 or less a minute and they're awake, the problem with hypothyroidism hypothyroidism, you go to sleep. It's like Undine's curse. You don't breathe as often, and you die of respiratory acidosis. And that's what happens to people if you forget to give them the paroxysm after surgery for several days. They can really become significantly hypothyroid and go into mixed hemochroma. But at any rate, having counted his respirations, and they were like 16 or 20 or whatever was in the epic. How do you have epic? Right, okay. He doesn't remember epic, you're missing this whole time. Okay. Epic has everything already there for you, and if it's not there, you just take it out. Right? Okay, so again, what are you going to measure in this person? You're going to measure the free T4. You can also measure the total T3. The total T3, the American Thyroid Association told us last year, is in most labs more accurate than the free T3. So they suggest we measure that if we're going to measure T3 at all. So free T4 was normal. So what's the problem? The TSH is the problem. And lots of people have TSH abnormalities. I have a collection of people that work in the animal lab that come to my office for their care. And they're exposed to rodent antigens. And rodent antigens make antibodies that interfere with the TSH test. And so a lot of them have TSHs that just don't work. So what to do? Well, first of all, you ask the patient, are they taking their thyroxine? That is far and away the most common cause of an elevated TSH, is they're just taking it intermittently. And if you do that, the TSH keeps creeping up and up and up. It can really get quite high. So, number one cause. What do you do about non-compliance? What you're going to do is this is the ACE guideline, and it really works. What you're going to do is you're going to add up their total dose for the week. They're taking 100 mics a day, supposedly. You say, okay, that's 700 mics a week. And you talk to them, you say, realistically, how often can you take this medication? And if they say 2 or 3 times a week, you divide by the 2 or 3, give them that med and send them off. Tell them not to get religion and start taking it every day, but you want them to get their whole dose every week. And that works. I have teenagers that take 700 micrograms of levothyroxine once a week and do very well. You say, wait a minute, how come they aren't hyperthyroid? Well, the half-life's about a week, so you're gonna just cycle through once a week. You can't do it less often than once a week without getting into a few problems. But that's a nice way to treat non-compliance. Figure out how they're going to do it. A lot of my teenage patients call themselves on the phone. Have you noticed that teenagers, kids now pop out, I think, of the womb. You'll have to help me out, you guys, and they have their hand like this, and immediately in the delivery room, someone puts a teeny tiny phone in it, right? I think they're going to get contractions. All right. But at any rate, we can do that. They call themselves on the phone at some time during the day, and the phone reminds them to take their thyroxine. They say like that. Okay, the third most common cause is malabsorption, and we can take care of that. What you do is you increase the dose, or you use levothyroxine sodium solution. There is a solution of sodium thyroxine that comes in the capsule. It's a gel cap. No one's allergic to it. It's very nicely absorbed, and you just use that. TSH doesn't reflect the thyroid state. You said that, but the free T3 and free T4 are normal. So those are the rodent, work in the rodent lab people. So just don't let it worry you or the patient. If the TSH doesn't work, move on. You don't have to get fantastically expensive tests. Okay, this is one of my favorite kinds of people. And they always come into my office at about 4:30 in the afternoon. It's a 54-year-old CEO with primary hypothyroidism who's taking levothyroxine 75 micrograms, and she says she wants a more natural hormone because she has fatigue. Okay? And so what do you do? Well, the first option is I check the TSH and the free T4 and free T3 and total T3 and everything else if she really wants to do that. I don't check reverse T3. Don't check reverse T3. It's a detoxification mechanism that's very good, and it gets rid of T3, so it's not going to make you sick. But if the reverse T3 is high, low, or different, you can't do anything about it. So don't check. Okay, so here she is, and she says, I want to do this. I say, okay, option number 1. Are you adequately replaced on your present dose? Remember 1.7 mics per kg per day. And so I get a TSH again, and I calculate the dose. If her TSH is higher than 2.5, fix it, raise the thyroid dose. I mean, you don't know what she was before she got hypothyroid. She may have had a TSH of 0.4. So she just may need more thyroxine, and you can give her more thyroxine. Okay, oh shucks, TSH is 1.8. So option number one gets rid of about the problem in about maybe 30% of your patients. They just don't have a TSH of less than 2.5. But she does. So that brings us to the unhappy hypothyroid patient. How many of you prescribe, the endocrinologist can't vote here, but how many of you prescribe desiccated thyroid or combination thyroid? Okay, looks like good business for us, right? Okay. All right, so I use Farmer Thyroid because it has the largest number of doses. Now that's changing, and the other people are developing more doses, but you cannot cut these desiccated thyroid pills into halves, because when you even use a pill cutter, they can crumble up. So you really need to pick on a good number of doses. And remember that the pig has more T3 than you and I in the desiccated thyroid. So if you're giving this to an older person, you're giving them a lot more T3. They're going to change it to reverse T3. They're probably have a good enzyme system. But initially in the morning, when they take their pill, they're getting more T3 than they would be if they were making it themselves. So remember that when you treat these people. In addition to that, 100 mics of L-thyroxine, you're going to do this, is roughly speaking the same as about 50 milligrams of desiccated thyroid. It's approximately the same. You say, wait a minute, excuse me, what do you mean approximately? That's what the pharmacopoeia says. It usually doesn't say approximately. Approximately? Right. They get these off the slaughterhouse floor, and so they crack them up, and they take the thyroid out. You think they measure? No. And so these vary from batch to batch. So I tell my patients, buy at least 90 days of this thing. If you can, buy 180 days so that you will have a constant amount of T4 and T3 when you use these things. And be sure you check the TSH. You really have to be sure these people have enough thyroid hormone. And frequently the TSH is a bit low because they have more T3. So you may end up checking the total T3 and the free T4. And I try to do that in these people. I try to make sure the TSH, the total T3, and the total T4, the free T4 are normal. So it's a little more bothered, but you can do it. Charge by the minute. Okay, any questions about that one? I'll stop asking this. If you have a question, for goodness sake, ask it. Okay, case 6. What is happening here? These people have no symptoms of thyroid disease, but look at them. 76-year-old female into the ICU with urosepsis, and oh look, the TSH was low. That sounds like hyperthyroidism. Aha, the free T4 was at the upper limit of normal, and the free T3 was low. 18-year-old woman, DKA, thyroid stimulating hormone 6.25. Oh, TSH is too high. Free T4 is 1.38, upper limits of normal. Free T3 is low. So what do these guys have? They have Euthyroid 6 syndrome. So when you're sick, the hypothalamus and pituitary get confused, and as a result, your TSH may go up, maybe a little high, maybe a little low, but the key here is, number one, avoid obtaining a TSH in seriously ill patients and use a free T4, because that's going to give you the clue the vast majority of the time. You wouldn't give T3 to either of these people that are extremists. Actually, they tried that. They said, okay, here are these people who have, they were in a burn, and they were very ill. And they said, okay, the free T3 is low in a bunch of these people, so they randomized them. They said, we'll give T3 to these people, we won't give T3 to those people, and we'll see what happens. The people they gave T3 to died more often than the people they gave T4. So they caught on that when you're an extremist, your body produces perhaps less T3 than it otherwise would, which decreases your basal metabolic rate, which perhaps helps you live Okay, will we give an antithyroid drug to the man? No. Repeat the thyroid function test in 4 to 8 weeks and include a 3T4. Guess we would. So again, I see this all the time in the intensive care unit. We must get at least 3 consults a month for a slightly low or slightly high TSH in the intensive care unit. It's not the time to measure it, and you're just going to repeat it in about 4 to 8 weeks when they are hopefully better. The 3T4 is the key here. It's virtually always normal. Okay. Okay, now let's look at subclinical disease. This is very controversial, by the way, and there's about 80 pages of guidelines about it now. 34-year-old lady screened for National Thyroid Month. Okay, who do you think comes in to be screened for National Thyroid Month? People are feeling really good? No, people think there's something wrong with their thyroid. So she's nervous, that's hyper. She has fatigue, that's both. She has excess weight gain, that's hypo. She has hair loss, that's hyper. She sort of has a mixed bag here. TSH is 4.5, which is elevated. 4 is normal. Oh dear. 3T4 was normal. So she has subclinical hypothyroidism. And I will not ask you to raise your hand if you treat her. Let's just go on here. Look at what subclinical hypothyroidism is. Remember that TSH is very sensitive. And so it means that part of the time, the TSH is up above normal. It means that part of the time, the 3T4 and 3T3 are slightly low. Remember our first slide where the T4 and T3 feed back to the pituitary and the hypothalamus. Very sensitive system. So the Endocrine Society just empowered a panel of people, a group of experts, and they flew to Zanzibar someplace and they paid them to look at all of the data about subclinical thyroid disease and tell us what we ought to do. Well, pharmaceutical companies help, of course, fund this little trip to Zanzibar. And so they looked at all the stuff and they said, you know, there's no evidence that treating people with a TSH of less than 10 is going to do any good for morbidity and mortality. Well, now you can imagine what the pharmaceutical companies who paid this gigantic bill really thought about that. They were unhappy, to say the least. So the Endocrine Society shuffled its feet and said, but, follow your clinical judgment and see if your patient will benefit from therapy. So it's up to you. Tell me like it is, sir. Okay, so there are therapeutic benefits. You decrease the cholesterol, your weight goes down by 5%. There are therapeutic risks. It increases your myocardial oxygen demand, it increases your bone turnover. If you're not enough calcium, that increases your bone loss. And of course, in patients over 60, you can have a risk of cardiac rhythm problems. So, if you decide to treat, pick some symptoms. Now that lady had a laundry list of symptoms, so I say to them, you're going to keep a diary. Today, right now, right in my office, we're going to decide on a scale of 1 to 5 how much these symptoms that you just listed, your hair loss, your weight gain, how much they bother you. And then we're going to see if they change in 5 or 6 weeks. I'm going to put you on, first I'm going to put you on your calculated dose of thyroxine. Don't use a weaning dose. You know, then they'll say, oh, not enough. Calculate the dose, put them on it, and stay there for about 5 or 6 weeks more. It's probably going to take you maybe a couple months here. And then get another set of thyroid function tests. And look at your diary. And if their symptoms didn't improve, get them off the thyroxine. If they did, there's no harm in keeping them on a replacement dose. But you don't want to overtreat. Your goal is a normal TSH, 2.5. Okay, there are some people where you ought to treat subclinical hypothyroidism no matter what. And they're the people with high TPO antibodies or thyroid peroxidase antibodies, people with thyroiditis and a relatively higher TSH. The TSH is 8 and their antithyroid antibodies are 1,010. They're probably going to progress onward. That's a judgment call too. Always, people with chronic renal disease, the kidney folks are telling us that they progress at a slower rate if we treat them. Because remember, thyroxine raises your glomerular filtration rate. So you may be helping those people out. So treat the people with chronic renal disease. The American Thyroid Association says treat pregnant patients with positive TPO antibodies, because we know that if you're pregnant and your TPO antibodies are positive, the fetal wastage rate is higher. We do not know that treating these people is going to reduce the fetal wastage rate, but certainly isn't going to hurt. Okay, so look at the cause. Generally speaking, in younger patients, it's thyroiditis. About 80% of the time, according to the ATA, it's thyroiditis. Older patients, usually medication-induced thyroiditis. And this is a lady who is older. She's 72, she had angina and tachycardia. She was on amiodarone, and we said that's our most common cause of iatrogenic thyroiditis in the United States, amiodarone. Her TSH was 10. And her free thyroxine was 1.2. Now, in this lady who is 72 and has angina and tachycardia, do I really feel comfy putting her on thyroxine? Give me angina to put this lady on thyroxine. I said, ma'am, you know, your free thyroxine is pretty normal and your ejection fraction is good. Now, in this lady, what's your goal for therapy? So the TSH less than 2.5? Oh. The goal of therapy here is a good ejection fraction. Now, this is a lady we said, remember your cardiac contractility is low when you have isovolemic contraction more of the time. You don't pump out as much blood. Ejection fraction is lower when you're hypothyroid. And in this lady, my goal is to have her ejection fraction be okay so she can walk around and be reasonable. I'm not going to fix her TSH, okay? So I said, well, we're not going to treat this now. We're going to wait. But if you wait with amiodarone on board, we've got to check pretty soon. And we checked in a month. And in a month, unfortunately, her TSH was 30, her free T4 was 0.6. Amiodarone-induced hypothyroidism can move really fast. She had a pericardial effusion. Oh dear. Okay, so her ejection fraction was down to 30. Now, did I not say to this lady, if you're short of breath, give me a ring? But people don't do that, so just get the TSH really pretty quickly. And so we fixed her, and she did very well. We put her on actually about 12.5 micrograms of L-thyroxine, and we titrated it up. She did very well. Okay, so iatrogenic hypothyroidism, we said amiodarone, but lithium, interleukin 2, high-dose iodine. Any kind of chemotherapy takes a whack of the thyroid because the cells turn over pretty rapidly. And usually you get hypothyroidism with these. Okay, so we're shifting gears and we're going to go to subclinical hyperthyroidism. That's a low TSH and a normal circulating thyroid hormone. And that means that part of the time the circulating thyroid hormones are too high. And in younger patients, that's thyroiditis and thyroiditis. In older patients, it's frequently multinodular goiter, and you never want to miss that. Because multinodular goiters have a higher incidence of thyroid cancer, and they grow if you don't take care of them. They can give you difficulty swallowing, difficulty breathing. So you need to find the multinodular goiters. Okay, so what are you going to do on all these people? Obtain an ultrasound. And there are guidelines for this. The ATA said last year that if the TSH is less than 0.1, we're going to treat people, particularly if they're over the age of 60, because the risk of arrhythmias is very high in this group. You get increased atrial fibrillation. You also get increased bone loss, and they have a higher incidence of vertebral fracture. So you're going to treat these people. The ultrasound is imperative. You've got to find out if they have a multinodular goiter. And again, if you look at this slide, if you look at the overt hyperthyroidism at the very top in blue and the red subclinical hyperthyroidism, those are superimposable curves with a risk of atrial fibrillation. So your patient with subclinical hyperthyroidism, TSH of less than 0.1 has the same risk of AFib as your hyperthyroid patient. So, Here's case 9. She's a 22-year-old lady, and somebody didn't read that first slide well and got that thyroid screen, even though she was asymptomatic, coming in for a well-done exam. And her TSH is 0.1, and had been their way for the last 5 years. And she's asymptomatic, everything else was normal. If this is the first time you met her, and you made the mistake of getting this TSH in the first place, just the U.S. Preventive Health Task Force says, check again in 3 months. And we're hoping this thyroiditis will go away. If it's a set point abnormality, it'll be the same. Frankly, there's no evidence for that, either one. But checking again is always a good plan. It's like when your computer doesn't work and you call the help desk, and we were talking about this, and they say, did you reboot? Right. It's similar to that. Okay. Observe these people. And in fact, if you're going to follow them at all, please follow a free T4. We see some of these people. I saw one about a week ago that had been to the endocrinology 3 times in the last 3 years for the same TSH that was 0.3, and our normal is 0.36. So again, they're just out of whack. Remember that normal is a 95% confidence level, and people are going to fall outside it. If they fall outside it once, they'll probably do it again. Please just follow a free T4, and if they have symptoms, get the free T4 with having symptoms. If they don't, just follow the free T4 anyway. This is well tolerated in pregnancy. You don't have to treat subclinical hyperthyroidism. Huge study, 7,000 pregnant women with subclinical hyperthyroidism. As long as the free T4 was normal, there wasn't a problem. Now, what are the consequences? Particularly in older people, the risk of AFib goes up a little bit. There's a slight increase in embolic disease. How about your young people that you're taking care of, your young women? Yes, there's increased risk of AFib, but the absolute risk in young people is very low. What there is, if you have them on an oral contraceptive, or they have any kind of clotting disorder, then those people are highly likely to develop coagulation problems, so they're likely to develop thrombotic events. So you need to tell them, again, particularly if their absolute risk of thrombotic events is high, you may need to put them on an aspirin, you may need to put them on some minor anticoagulant, or you can tell them to exercise. Good anti-thrombotic agent. But remember those folks on the OCs who have subclinical hyperthyroidism. Okay, so this is a 75-year-old lady with AFib, large extremity DVT, and a large nodular thyroid. She's your multinodular goiter. By the way, you don't want to wait until you can see that. You want to just hopefully find it before. She has osteoporosis, so she's had all of the problems, and she still has subclinical disease. So that's the reason you want to treat these people with a TSH of 0.1 or less, because otherwise they progress along to the complications, and you haven't done them a service. Okay, how are you going to treat these people who have multinodular goiters and have hyperthyroidism, even if it's subclinical? How are you going to treat all these people we just said? TSH of 0.1 or less, you're going to treat them? How? We're going to use methimazole. And we use methimazole because it has a much lower incidence of liver failure. Remember that our antithyroid drugs can cause liver failure. 1 person in a million or so on methimazole, less often than propylthiouracil. And so, generally speaking, in adults who are non-pregnant, use methimazole. The goal is to have the TSH in the mid-normal range. You don't have to have them low or high. Normal TSH. And discuss the possibility of neutropenia and granulocytosis. Again, very rare, about 1 person in 500 to 1,000, but nonetheless, you need to think about that. And again, discuss the remote possibility of liver failure. But you're using tiny doses here, and so you really don't see many side effects of tiny doses. Okay. So this is a 22-year-old lady with weight loss and nausea, diarrhea, muscle weakness. She delivered a healthy boy about a month to maybe 2 months ago. She's breastfeeding. She said, I just feel crummy. Okay. On exam, look at this blood pressure, 150/60, high systolic, low diastolic, pulse of 100, weight's 92, she's 5.6, she's lost some weight, she lost all of her pregnancy weight, lickety split. Right away, you know that's a pathological condition. Okay. She has no signs of bulimia. Always look at these young people. You want to make sure that they don't have erosion of their enamel. You want to make sure they don't have a lot of abrasions in their mouth, putting their long, stuck-on fingernails down there to cause vomiting. Her thyroid is pretty normal. It felt okay. It wasn't tender. Oh, look at that TSH. That is really low. So she has hyperthyroidism. Is that subclinical? Oh, those are normal. But that really isn't subclinical. She's sick. Subclinical thyroid disease, people are generally speaking asymptomatic, or they have a laundry list of things that couldn't possibly get from their thyroid. So again, this lady is sick. Well, we're old-fashioned here, and so we get an I-123 uptake. It was 2%. So what does that lady have? Thyroiditis. But luckily, we don't have to get that radioactive iodine uptake anymore. It is gone. Poof. Now the new Thyroid Association guidelines suggest that we can do other things. But again, laboratory doesn't correlate well on thyroiditis. Depends upon when you're at the beginning or the end. It's an inflammation of the thyroid. The hormones are just spilling out. And so there's little control over that. And the TSH sometimes is high, sometimes it's low, depending on whether they're becoming hypothyroid from all the thyroid inflammation and scarring. The uptake is generally low because the thyroid isn't making thyroxine, it's just spilling it out. It's inflamed, it's not taking up iodine. But then, the uptake can go up during recovery, so all of those are kind of iffy. But how can we make the diagnosis? You get a thyroid ultrasound, and they usually can tell. They can say, okay, it's heterogeneous, there are a lot of little cystic places in the thyroid, and a lot of times the ultrasonographer will just say, oh, it's thyroiditis. So even radiology can sometimes call this. So anti-TPO antibodies may be higher normal, but I generally get them. And what you're looking for is you say, gosh, I don't know if this patient has, I know they have hypothyroidism, but I don't know if they have thyroiditis, which is postpartum thyroiditis. It's going to go away all by itself. Or do they have Graves' disease? So that's your quandary. And so now, instead of getting a radioactive iodine uptake and exposing them to radiation, you get a TSH receptor antibody. The TSH receptor antibody is the actual antibody that causes Graves' disease. So in Graves' disease, it is higher. It is always there because that's what's causing the disease. So there you go. You get a TSH receptor antibody. You can order that pretty easily. In most systems, it's TSH-RA or receptor antibody-TSH in most of the electronic systems. And you can tell if it's not Graves' disease and it really is thyroiditis, it resolves spontaneously in 2 or 3 months. It may return. If it's postpartum thyroiditis, it returns every time you deliver. It's just, I think it's 80% recurrent. So yeah, it comes back. I'm sorry. Most people with thyroiditis, they get it once clinically, and then maybe a subclinical thyroiditis that eventually causes hypothyroidism, but they usually don't have symptoms over and over again. So when they have symptoms, treat it. Buffered aspirin, and it says the tachycardia warning is a fairly tiny dose of beta blocker, usually something like 10 milligrams of propranolol, sometimes twice a day will be enough. Short course of steroids if they're very symptomatic. I mean, something like just a dose packet of steroids. Follow the TSH until it's normal, and then get it 3 months later because that's when they may develop thyroid failure. If you have enough inflammation with thyroiditis, you're liable to develop thyroid failure subsequently. So you don't want to miss that because then they're going to become hypothyroid, like that lady who came to the ER with a TSH of 116. If the patient has multiple recurrences, they probably want surgery. I had a guy I know, he's a man, female patient, but he had every spring for 3 years, he came in with AFib with thyroiditis. The 4th spring, I said, don't you think we ought to get rid of this thyroid? Okay, so let's take a look. We're coming to the end here, don't give up. Mild hyperthyroidism. Long-term meds are now approved by the American Thyroid Association. It's a 43-year-old lady. She had palpitations. She lost 5 pounds over the last 3 months, and her mother had hypothyroidism. On exam, look at her again. High systolic, low diastolic, pulse of 90. She had a non-nodular goiter. Lab TSH was low, pre-T4. This is elevated in our lab. 1.46 is our normal. And so she said, no, I don't know. She had thyroiditis. She had Graves' disease. If you look at people with Graves' disease, they're vibrating in their office chair, their TSH is really high. You usually can differentiate, but you're not ever sure. So once again, we're going to get our TSH receptor antibody. If it's greater than 6, normal in our lab, you have to find out what normal in your lab is. Normal in our lab is about 1.75 or less. So greater than 6, TPO antibodies are elevated, but they frequently are in Graves' disease. So don't let that bother you. As long as the TSH-RA is elevated, the patient has Graves' disease. And so what are we going to do? We're going to use long-term methimazole. She said, I don't want radioactive iodine. I don't want surgery. I want the natural way. I said, I'm sorry, ma'am, there is no natural way. So how about long-term methimazole? You normalize the TSH, and you have to take the medicine, take it once a day. Methimazole is once a day. PTU is twice a day. Methimazole is once a day, at least a year. And remember, you're going to look at the white count, you're going to look at the liver function studies. You get agranulocytosis, you can get neutropenia, you can get failure. So periodically, isn't that helpful? Don't you like it when these bodies who give out guidelines say, well, you know, you should check this periodically. You know, when they come in, I have these people come in about every 6 months because I want to make sure they're taking the methimazole. What's the most common problem here? You don't get resolution for your hypothyroidism. It's not taking the med. You really have to take this every single day. Remember, it stops the thyroid from making thyroxine. So again, every single day. And if they're symptomatic, I use a beta blocker. There's about a 30% remission rate in a year. So these people with mild thyrotoxicosis, this is their opportunity to lose a bit of weight. You normalize their TSH, and they can eat more. So anyway, a lot of them want to do this, and it's fine. But remember, you got to keep track. This is only a 30% remission rate. So it's a 33-year-old lady who's trying to lose weight. She has tachycardia. She has thin hair. She's lost some weight. And she has no history of thyroid disease, and she's taking a lot of herbals. So on exam, she has a high systolic, a low diastolic, tachycardia, no goiter. That's okay. Lab, oh look, same as our previous lab. And we said, she have Graves? Do subthyroiditis. Uh-oh, look at that. Oh dear, they're both negative. They're both totally negative. What does that suggest? You have to be sharp to get this one. What does she have? She has no TPO antibody. She's hyperthyroid, to beat the band. And she has neither one of these antibodies. They're both negative. Well, you know what she has. She has been taking thyroxine. Or actually, she went across the border to Mexico. We were pretty close to the Mexican border. She went across the border to Mexico, and she bought this bag that looked like leaves and sticks. And she brought it to my office. She said, I'm taking this to lose weight. It's working pretty well. And she had been taking, among other things, thyroxine. And her IL-23 uptake, if you want to do that, you could, is 0. And her thyroglobulin is low. Remember that thyroid is the only organ in your body that produces thyroglobulin, and it produces thyroglobulin. If you are normal and you're not taking excessive thyroid, you have to shut it off. So that's the way to find out if people are actually sneaking thyroxine in. She didn't realize she was doing this, by the way. Okay, rounding it up, here's a 22-year-old lady with Graves for about a year. And Graves' disease can kill you if you let it persist, and it will. We lost somebody about 3 weeks ago that just died from cardiomyopathy. He was eventually did cardiomyopathy, and they tried to do a heart transplant, and in the process, she couldn't get off the pump, and she died. So, you want to treat Graves' disease aggressively early. For 12 weeks, she had weight loss, her heart was racing, she had diarrhea, she had tremor. She'd gotten much worse over the last 3 months, and her family brought her in because she couldn't get up off the floor. She got down to play with her child, and she just couldn't get up. So, look at her blood pressure, 90/60, her pulse is 130. She had proptosis, and we sent her to ophthalmology. Did I spell off? I did spell ophthalmology. I could never be an ophthalmologist. I spelled it wrong again. Okay, thyroid was enlarged, no palpable nodules, and she had no edema. She didn't have heart failure, so that was great. And she had terrible proximal muscle weakness. Obviously, she couldn't get up off the floor. She had a tremor. She had an enlarged spleen. Remember, people with Graves' disease can have splenomegaly and nose, neck, positive nose, because they have a systemic disease. And frequently to treat them, the spleen gets smaller and the nodes disappear. Okay, so look at her laboratory. The TSH was so low, it was undetectable. The free T4 was 8. 1.46 is normal. And free T3 was 16, so it's 4 times normal. This lady was at risk of thyroid storm and death. She's more likely to develop eye disease if she has a smoker or free T3 is very high. If you have a person with hyperthyroidism that comes into your office and they smoke, you've got to get them off the cigarettes. I mean, eye disease is so much more common when you're smoking. So, when you see someone with hyperthyroidism, you say to me, oh, I'm not going to treat that lady, I'm going to send her right down the hall. Okay, before you do that, look. If her extraocular movements are not intact, or there's proptosis, that's an ophthalmologic emergency, no matter how you spell ophthalmologic, and you need to send her to the eye doctor. And it's very simple to look. It's just, I'm not blessing you, it's this way, and that way. And it takes you just a few seconds. They follow my fingers. And you can tell if they have extraocular movement problems. And if they do, it's right over to the ophthalmologist. Tachycardia with low blood pressure. Those people are dehydrated. And we need to slow them down. And when you slow down their heart rate, actually the blood pressure goes up. Because they didn't have good filling time. They're beating so fast, the heart can't fill. They get better cardiac output if you actually slow them down. Proximal muscle weakness. I'm a small person generally, so I have people do it against their own force. And I say, okay, put your hands together and then stand up out of the examiner chair. If they can't do that, they have significant proximal lower extremity muscle weakness. And that's a good way to do it. You ask people to squat. Most people in the United States now, we're so obese. We aren't exercising, and most people can't get up from the squat. So that used to be the old test. The new one, American Thyroid Association says standing up out of a chair. Okay, she had dehydration, diarrhea, and hyperfiltration, and so she's really dehydrated. When are you going to hospitalize this person instead of sending them to the endocrinologist? If they have vomiting, they can't take their meds properly, or they have a fever. A fever is thyroid storm until proven otherwise. But taking their meds properly reminds me of this pregnant lady with hyperthyroidism, and remember in pregnancy, you're getting is propylthiouracil the first trimester. I'm going to economists change that. The ATA says you can use methimazole the whole time, but many of the OB/GYN people feel you should use propylthiouracil in the first trimester and then switch to methimazole. Propylthiouracil is more likely to cause the problem with liver failure. So, at any rate, this lady never took the pills, and she kept coming into the hospital because she kept getting vomiting and fever, and she never had thyroid storm. But believe me, she came in 5 times during her pregnancy into the hospital so we could give her her meds. And I was telling you that when a baby is born in our institution, they play this little lullaby. It's like a little loudspeaker system, so we'll all know there's another paying customer in the system. So, I have never heard anything so wonderful. So we were up in labor and delivery, and there she was, finally, of course, and we were poking pills down her. And the lullaby said, that's the greatest sound I've ever heard of that lady giving birth. So, what are you going to do with these people? You say, oh, I'm not going to treat them. Okay, fine. Beta blocker. Please tell them hydration. Oral hydration is fine. Beta blocker. Non-cardioselective, please. Propranolol. And just get them started like 10 or 20 milligrams 4 times a day. That will be so helpful. It decreases their risk of thyroid storm. If you feel comfortable, you're going to use high-dose methimazole. It's not 5 milligrams BID. It's about 60 milligrams a day. And then, okay, monitor periodically the liver and the white count. Send them over. And if they have muscle weakness, you could also get them started with dexamethasone, which decreases conversion T4 to T3. T3 is the active hormone, particularly in the muscle. And so you're going to just fix that. And the next day, they usually could stand up without any problems. So again, these people with severe Graves' disease, definitive therapy every single time. And that lady, postpartum, she rolled out of the delivery room and we said, and how would you like to have surgery today? So she did agree. So she had had Graves' disease for about 5 years and was developing cardiomyopathy. So again, don't let your patients get to the point where they're developing cardiomyopathy. They're young, they feel like they're immortal. You need to make sure that they know that they aren't. The lady we lost was 22 years old. Okay, so again, definitive therapy as soon as possible for the severe Graves' disease. And finally, we're finishing. We decided to hang on a little extra because we don't want to get in trouble with the accreditation bodies who want to be a little longer here. So, subclinical disease, use your clinical judgment. You know, really, if you can treat something, fine, but make sure you know what you're treating and the patient is focusing on that. Thyroiditis is supportive therapy. You can use a little beta blocker, a little something for pain, maybe some steroids. But you want to make sure that you look after the thyroiditis is over and make sure the patient isn't hypothyroid. Hyperthyroidism, most people need definitive therapy unless it's really very mild. And finally, if you're looking at replacement, remember we said 1.6 mics per kg per day. For primary hypothyroidism, we're going to follow the TSH. For secondary hyperthyroidism, we need a normal free T4. That's what you follow. Thyroid cancer, how many of you take care of thyroid cancer at all? No, okay. Well, in one or two of you, it looks like endocrinologists keep the people with high-risk thyroid cancer because there's a lot of forms to fill out. We're really good at that. But basically, the low-risk people are going to go back to you because thyroid cancer is fairly common. And if you're low risk, it should say in the note from the person who sent them, the oncologist or the endocrinologist, a low-risk patient, low normal TSH is fine. You no longer have to have those people suppressed. Your guidelines suggest low risk, low normal TSH. High risk, you want to keep them suppressed, but then again, we want other people to keep them, not because, again, it's a lot of work to monitor them. But that is it. So Randy has the questions, right? What is the most, these are simple. I mean, I wanted everybody to really do well in my section. What is the most effective test to diagnose thyroid disease? The TSH, the free T4. Oh.
Here we go.
Oh, wow.
Sorry
Thank you
about
very much. Okay, most of you got that. Next. But there are only 10 people this time. I think some people, I can tell, some people are not doing this. Okay. Okay. What is the recommended test to diagnose Graves' disease in your pregnant patient? Radioactive iodine uptake? That's an easy one. Everybody got that. Okay. By the way, how about neonatal Graves? We'll pause or something. How about neonatal Graves? Not common, but when it hits, it's not good. So what do you use to determine the probability of a pregnant lady, Graves' disease, of having a child with neonatal Graves? Use the TSH receptor antibody. Remember those old TSIs? Don't use that anymore because the risk of neonatal Graves is proportional to the TSH receptor antibody. And that's why you treat those pregnant people pretty aggressively in the first and second trimester, and then as the third trimester comes, remember that the hyperthyroidism frequently remits. It's like rheumatoid arthritis. It frequently goes away in the third trimester. You can get rid of most of the propranolol. You can get rid of the dexamethasone you've been on. You shouldn't totally get rid of the methimazole unless their TSH is really normal, because when you get rid of the methimazole, the TSH receptor in the body can go off again, and your risk of neonatal Graves goes up. Okay, so, oh wow, that's more people are voting. I like this. Really, it depends on the clinical situation. Absolutely. Is that it? That's it?
Got one more?
Oh, one more, okay. Is in a hyperthyroid pregnant patient, you would treat with, oh, here we go.
Well, hold on a second here. There we go.
There we go. Timing is everything. Although some people do use the methimazole the entire pregnancy, you might be slightly at risk legally by doing that because the ACOG, I think, still says use propiondiricil the first trimester, although ATA says You finish all fine. Okay, go ahead.
One more?
One more. Oh.
Yep.
Okay. Thyroid hormone may be taken, okay, in the morning, the same time as your multivitamin, at bedtime, separated by non-vitamin. Calcium supplements, anytime is okay, just not, just not with any other medication. No, right, very good. So, the vast majority of people got bedtime separated by an hour.
That's it?
Okay. Are there any actual questions from the, yes? Right.
The 72-year-old lady who had subclinical hypothyroidism, would you get a DEXA scan of her and maybe treat her with bisphosphonates if she's outside of that window of estrogen therapy?
Yes, I would. That's a very good question. What would I do with that lady's osteoporosis, who is the 72-year-old lady? Yes, I would treat her with a bisphosphonate. And in fact, if you find those people early, you can treat them early with bisphosphonate. And the whole key is to try and prevent fractures. So, excellent thought. Yes, back there in the, do I dare throw this?
Throw it. Throw it.
But you wouldn't want to knock the bar over.
Do you have any web ones? Do you have web questions? Yeah, I'll check.
All right, here we go.
What's the role of checking TPO in subclinical hyperthyroidism?
Okay, why would I check the TPO antibody in subclinical thyroid disease? It tells you if it's with like 50, tells you pretty much nothing. Normal in our lab is less than 9. If it's 152 or 5,056, people have thyroiditis. Would I treat them differently? Well, no and yes. If the TSH was in the 3 and 4 range, I might wait it out. But if the TSH is 9 or 8, I'm probably going to treat them because they're probably going to get hypothyroid. So it tells you about thyroiditis. And when you have somebody with thyroiditis, it tells you a little bit more, is it more active? I mean, it's an inflammatory, it leaks out, it's an inflammatory state. So it tells you kind of about the activity of thyroiditis. It may help you decide who you're going to treat because they're more likely to develop hypothyroidism. So those are 2 things.
So TSH is normal and TPO is abnormal. Patient complains of fatigue. Would you just go based on TPO and treat?
That's a very good thought. But I treat the person with fatigue with the TPO antibody that's elevated. And generally speaking, if the TSH is normal, it's like, 3 or 4. So, no. What I do is give them my discourse about how thyroiditis is a systemic disease, and so you may not feel quite as well. So you just kind of, it resolves itself, and just have the people around you be more supportive. It's I'm not going to treat you, but even though you got a minor disease. And your fatigue is probably not from your thyroiditis. So, no, but you could. The American Thyroid Association and the Endocrine Society say if you think this patient will benefit from being treated, go ahead. If they have subclinical disease or TPO is high, try it out. Don't overtreat them. You got to watch it. And thyroiditis,
You can read, or you want me to read?
they're spilling out hormones. So you give them thyroxine, you got your thyroxine plus their thyroxine.
I'll get the book.
Because their thyroid
Sure, I could just
is
stick it
putting
in
out
your
hormones and it's uncontrolled release. Okay. Good question.
One question. How did you determine those sticks were thyroxine? That lady brought those sticks and was all.
How do we figure out what's in the Mexican medicine bag? Oh, well, we have a really nice, we have a really nice reference layout, and they also do drug monitoring, and so you can give them a gamish of some sort, and what they do is they just wash out thyroxine is soluble water, so they just washed out. They whizzed out the bag where and they just ran through your hyperthyroid chromatography, and they said, hey, you know what's in here? Actually, they're amphetamines and thyroxine.
Quick question about pregnancy. Would you follow, if you needed to follow AT4, do you follow 3T4 or total?
Oh, that's the controversy. And, there was a mixed thought about that in the ATA guidelines. They suggested you follow the TSH. The new pregnancy guidelines suggest you follow the TSH. They
But
don't
I mean, if you
suggest-
have a hypothyroid. patient. If
I see. I'm
if you
treating
need to
hypothyroidism.
know
Right.
T4 or free T4, what would you follow?
If I have a choice, I follow the TSH and I get it back in the normal range. That's our policy for that. But you can I follow the free T4. Some people are going to follow the total T3, but in most labs it's not as accurate. And so in our lab, and if your lab is different, you can follow what you want to follow. You want to keep them normal. Whether you're following the TSH, the free T4, or the free T3s, you want to keep them normal. In our lab, either the TSH, we have a reference lab for the region. The TSH or the free T4 are both really pretty reliable. And so I follow one of those too. If you have another thought, though, this is our endocrinologist of the week.
No, I was actually asking specifically about free T4 versus total T4.
Oh, yes.
Pregnancy.
Does ACOG still say follow the total T4? They used to, but now I think virtually everybody is following the free T4 or the TSH. The total T4, they used to say follow the total T4 and keep it slightly high.
Right.
High being we don't know what, but.
Yeah. Thank you.
Okay, we have some questions from the webcast. Is there a range in the level of positive TPO antibodies that are considered not significant, or will most of these people progress to hypothyroidism?
And that's a very good question. Most of the people won't progress to hypothyroidism. Luckily, most of us can have thyroiditis, and we don't, unless it's reported, we don't get hypothyroidism. So only about 20% of those people are going to progress at their first attack. And so if the TPO antibodies, again, depends on your lab, ours greater than 9 is abnormal. So if there are 100,056, I say, Mrs. Lab, we got to watch this carefully. But on everybody, you need to get that TSH 3 months later, 3 months after they've recovered, because your TPO antibodies are just a point in time. And so, today they may be, I've seen people go from, say, 50,000 to 200,000 over the course of a couple of months. So, if the hypothyroidism persists, it's their judgment. That's a comment.
So the next question is about Hashimoto's disease and whether or not you use cytomel.
Okay. Do I use, in Hashimoto's disease, when I'm replacing them, we'd have to ask, oh dear, you'll have to send that one in again. If you're a quick typist, you're okay. In Hashimoto's disease, I don't necessarily use T3. I use T4 to replace virtually everybody unless they want desiccated thyroid. Yes, I do use desiccated thyroid. If you're replacing with combination T4 and T3, you're going to measure total T3 and free T4 in every single one of those people, and you want those to be absolutely normal, as well as a normal TSH. So it's a lot more work for you to do that.
Is there a range in the level of positive TPO antibodies that are considered not significant, or will most of these people, we did it?
I think we did that.
Yeah, right, okay. For the primary care docs, if we suspect thyroid disease, what initial blood tests should we order, when to refer to endocrine?
Okay. The answer to that question is, if we suspect thyroid disease, what's the first test we should order? TSH. There we go. Very good. These people are really very sharp today. Okay, a TSH. Now, when should we refer to the endocrinologist? Well, for most providers give thyroxine. We use that 1.6 mics per kg per day. Give that a go, unless they have angina. So if they have complicated hypothyroidism, you might want to refer. If they have angina, if they have some other problem that could impact on the thyroid hormone replacement. But otherwise, hypothyroidism is pretty easily replaced. Most providers do not want to work with hyperthyroidism because people can die. And they really can die pretty suddenly, particularly elderly people with multinodular goiters that are thyroid toxic. They frequently die from BFib, and they may not have many symptoms before. So if you see a toxic multinodular goiter, you're probably going to want to refer that.
If I prefer not to check both total T3 and free T3, which would you recommend?
The American Thyroid Association says total T3 is more accurate in most labs, and so they would suggest you to.